I'm really sorry I couldn't do the class yesterday. There was Rheumatology වැඩ ඉවරන කොට ඒක මංජන් වැඩ තිබුණා. Hi. Okay. Right. So rheumatology. I thought පොඩ්ඩයි තියෙන්නේ hematology and infectious disease විතරයි තියෙන්නේ මේක කරාට පස්සේ. ඒ දෙකම හෙට කරන්න පුළුවන් ගොඩක් දුරට. Right. So the first few MCQs is on osteoarthritis. Osteoarthritis. Now, the important points to know about osteoarthritis is number one, that it's commoner in females and the incidence increases with age. Right. Now, there are three main types of osteoarthritis, which is based on the joint pattern, right? So we classify osteoarthritis into three clinical types based on the joint involvement pattern. And these are generalized nodal osteoarthritis, hip osteoarthritis, and knee osteoarthritis. Right. So let's take the first MCQ. Right. So is more commoner in males? It is definitely much more commoner in females. Right? Definitely much more commoner in females. Now, if you take the three clinical types, say generalized nodal osteoarthritis, hip osteoarthritis, knee osteoarthritis, the next slide gives you some information about nodal osteoarthritis. So generalized nodal osteoarthritis. Now, again, it follows the similar pattern where the incidence is commoner in females. And there is a familial association. There is a familial association. And nodal osteoarthritis causes a symmetrical polyarthritis. It's not arthritis, it's a polyarticular involvement. Right? It's a polyarticular involvement. Right. මට විනාඩියක් අපර දෙන්න. Okay. So there's a polyarticular involvement and there's a particular involvement of the distal interphalangeal joint. Now, this is very important. Please write it down. This is the main difference between nodal osteoarthritis and rheumatoid arthritis, right? Okay. So in rheumatoid arthritis, as you know, the distal and interphalangeal joint is paired, whereas in nodal osteoarthritis, there is involvement of the distal interphalangeal joint. Right? The other difference, of course, is that rheumatoid arthritis is a polyarthritis, there is active inflammation. In nodal osteoarthritis, there is not so much inflammation. Right? There is not so much inflammation. Right. And you see the typical examination findings of Heberden's nodes and Bouchard's nodes. The Heberden's nodes in the distal interphalangeal joint and Bouchard's nodes in the proximal interphalangeal joint. And these patients with nodal osteoarthritis have an increased frequency of osteoarthritis in other parts of the body, like the knee, hip, and spine. Right. So let's go through this now. So more common in males, Bouchard's nodes are in the proximal interphalangeal joint. Joint deformities are rare in osteoarthritis. You can get joint deformities. Even in the fingers in nodal osteoarthritis and in the knees as well, you can get joint deformities. There's no doubt about that. Right? And we already talked about nodal osteoarthritis being associated with other types of osteoarthritis like hip and knee osteoarthritis. Right. Now, if you look at knee and hip osteoarthritis, so the X-rays on the left give you a nice idea of knee osteoarthritis, right? And you can see the very typical loss of joint space in knee osteoarthritis. And it's very important to remember for MCQs that in knee osteoarthritis, it is the medial compartment of the knee that is affected, right? Medial compartment. And on the right-hand X-ray, you see a very typical appearance of hip osteoarthritis. And in hip osteoarthritis, it's mainly the superior pole that is affected, right? Superior pole of the hip that is affected. And if you take the pathogenesis of osteoarthritis, it is an imbalance between the cartilage breakdown and cartilage reformation mechanisms, right? That is the general pathogenesis of the disease. So there is imbalance between the cartilage production and the cartilage breakdown. So knee osteoarthritis usually affects the medial compartment of the knee. It's not the lateral compartment. It is the medial compartment that is affected. So this is sort of an introduction to osteoarthritis, the various clinical subtypes of osteoarthritis. Okay. Now there are few more MCQs, and these MCQs are mostly focusing on the diagnosis of osteoarthritis. Now, osteoarthritis patients present with joint pain, right? Joint pain, which is classically non-inflammatory in nature, right? Non-inflammatory in nature. We talked about this in the long case discussion. When somebody presents with joint pain and you're thinking of osteoarthritis, we often use X-rays to confirm the diagnosis, plain X-rays. And what are the changes that occur on the X-ray? Right. So number one, narrowing of joint space. That is one of the first things that you see, narrowing of the joint space. And this is because of the breakdown of the cartilage in the joint. Okay, so there is narrowing of joint space. Once the joint space is narrowed, the edges of the bone start rubbing on one another. Right? They start rubbing and there is friction. And because of the friction, there is periarticular osteosclerosis. Right? There is sclerosis around the joint edges. Right? So joint space narrowing and periarticular osteosclerosis are two important features. Also, there are small sort of bony protuberances which are formed, which are called osteophytes. Osteophytes. So there is joint space narrowing, periarticular osteosclerosis, so sort of thickening of the bone around the joint because the joints are rubbing, the bones are rubbing on one another. There are formation of osteophytes. And also another feature that are not shown in these X-rays is that you get, here we have, on the right side, you can see subchondral cysts. That is another feature that you see in osteoarthritis. So I'll just point to that then. So you have the subchondral cysts here. Okay, method. So those are the four features that you see on the X-rays in a patient with osteoarthritis. So subchondral bone cysts are seen on radiography. That is fine. Okay. Now, even though we describe osteoarthritis as a non-inflammatory disorder, you do see that there are some features of inflammation which go on, right? Some features of inflammation, especially when there is a flare of osteoarthritis. So you do see that the CRP can slightly go up and you can have some neutrophils in the joint fluid. But there won't be a whole lot of neutrophils, right? Or very high CRP. If there were thousands and thousands of neutrophils, then you would think of septic arthritis. But so predominant neutrophils, but not a lot, not as much as septic arthritis. So there is some evidence that there is a bit of inflammation going on, not to the degree of infection or rheumatoid or anything like that. But in osteoarthritis also, there is some inflammation within the joint space, right? So CRP may be elevated and you can see neutrophils in the joint fluid, but it's not a lot of neutrophils, right? If there was a lot of neutrophils, you would diagnose septic arthritis, right? Now, and I have also given you, Metana, just a rough guide to the various sort of joint appearances, joint fluid appearances that you see, right? In various sort of conditions, right? Okay. Now, how do you treat osteoarthritis? Osteoarthritis is extremely difficult to treat because there are no disease-modifying drugs for osteoarthritis, right? We talk about disease-modifying medication for rheumatoid arthritis, but there are no effective disease-modifying medications for osteoarthritis. So most of the time, we have to just treat with analgesics, right? Paracetamol, NSAIDs, sometimes strong opioid analgesics can be used. Another thing that you do, especially when there is a single joint involved, which is quite useful, is intra-articular steroid injections. And this sort of works with the idea that I put forward earlier, that there is a bit of inflammation going on and the steroids sort of control that inflammation. So intra-articular steroid injections are actually very useful in patients who have single joint osteoarthritis, like knee osteoarthritis. And you would have seen patients being admitted to the ward for these sort of procedures. So intra-articular, so contraindicated clinical, we do use them sometimes. And of course, joint replacement, arthroplasty, is sometimes needed in patients with severe osteoarthritis. You need to replace the joint, right? Okay, and put in a prosthetic joint, artificial joint. So as I discussed, analgesia, intra-articular steroids, and surgery are the three main treatment options for osteoarthritis. And we do not have effective disease-modifying drugs for the disease yet, right? So this is one of the major lines of research that we use now, right? Try to find disease-modifying drugs for osteoarthritis. Okay, right. Any questions from osteoarthritis?
Sir, ESR වැඩි වෙනවා කියලා ගන්නවා.
Oh, ESR චුට්ටක් වැඩි වෙනවා. ESR CRP දෙකම චුට්ටක් වැඩි වෙනවා. හරි.
So make a predominant polymorphism.
Okay, predominant polymorphism is if you take the fluid, there are lots of ඒ fluid එක ඇතුලේ neutrophil තමයි වැඩි. ඒකයි එකෙන් කියන්නේ. මිසක් මේකේ neutrophil ගොඩාක් තියෙනවා කියන එක නෙවෙයි. ඒ fluid එක ඇතුලේ neutrophil තියෙනවා. And neutrophil is the main cell type within the fluid of osteoarthritis. That is what I'm asking in that MCQ. Right? Okay. Right. So nodal OA Sajid is also age related, not so much weight related. Age definitely, yes. Weight relation osteoarthritis mostly we see in hip and knee osteoarthritis. Nodal is more familial and is age associated. Okay. Moving on to rheumatoid arthritis. Okay. Remember again that there is a genetic component, and there one of the key genetic determinants are these HLA DRB1 and HLA DR4. Right. So these are the main genetic genetic associations of rheumatoid arthritis. The HLA genes, HLA DRB1 and HLA DR4. Again, like in most inflammatory joint diseases, this is commoner in females. And we talked about this in the long case. Rheumatoid arthritis typically presents with a bilateral symmetrical small and large joint polyarthritis. It's an inflammatory polyarthritis disease. And there is often symmetrical involvement in the small and large joints. Okay. True or false regarding rheumatoid arthritis is HLA DR4 associated. It's true. Can present with a migratory polyarthritis. Migratory polyarthritis. That is true. Sometimes we see that in the early stages of rheumatoid arthritis, you can get a migratory type pattern, right? That is well known in early rheumatoid arthritis. Migratory type pattern, right? Migratory type pattern is known to be associated. Now, in rheumatoid arthritis, right, there are some joints that are spared or more or less spared. And remember that the hip joint is very, very rarely affected, usually not affected, right? Usually not affected in rheumatoid arthritis. Another joint that is not affected is the distal interphalangeal joint, right? So remember that. Distal interphalangeal joint and the hip joint are spared in rheumatoid arthritis. Also, the spine is relatively spared as well. Right, so the axial skeletal joints, right, in the spine are also relatively spared as well. Right, so distal interphalangeal joint not involved, hip joint almost never, And then the axial skeletal joints are also preserved in most cases. So through MCQ we are asking you about the joint pattern, right? So involvement of the distal interphalangeal joint is common buru katawak, and spine is not commonly affected, right? So so it's a bilateral symmetrical small and large joint polyarthritis. Some joints are not affected, and those I have just described what joints are not affected. Yes, Achala, palindromic rheumatoid arthritis is another name for the migratory polyarthritis. Okay, that is another name for the migratory polyarthritis, and this is typically seen in early disease, early rheumatoid arthritis, where the joint can sort of joint pain can move from joint to joint. Right. Okay, so this MCQ focuses on the joint pattern that you get in rheumatoid arthritis. Right, now this diagram gives you a lot of MCQ points and make an MCQs. The extra-articular manifestations of rheumatoid arthritis. Right, so we have gone through this in the long case as well. And let's just go through the MCQs to see if you remember some of the extra-articular manifestations. Okay, so ocular complications, remember corneal complications, you can get corneal ulceration as well, are seen in patients with rheumatoid arthritis. Right. So true or false regarding the extra-articular manifestations of rheumatoid arthritis, scleromalacia perforans, so that is an ocular complication, a very nasty ocular complication, right? There is perforation of the sclera and thinning of the sclera, which is scleromalacia perforans. In the respiratory system, as you know, they commonly get interstitial lung disease, but they also get pleural effusions. And I told you, remember, in respiratory that these are low glucose pleural effusions. Low glucose pleural effusions. Another respiratory complication is a small airways disease that is called bronchiolitis obliterans. Right? It is a small airways disease which is called bronchiolitis obliterans. So statement 2 is true. And also they can get pulmonary nodules. And if they have pre-existing pneumoconiosis, coal-workers pneumoconiosis, on top of that, if they get rheumatoid lung, they get a disease called Kaplan syndrome. CAPLAN, Kaplan syndrome. So these are the pulmonary comps. So get a small airways disease, they get pulmonary fibrosis, they get pleural effusions, lung nodules, and nodules on the background of coal-workers pneumoconiosis is referred to as Kaplan syndrome. Kaplan syndrome. Now in the skin, they get various things, ulcers, pyoderma gangrenosum is associated. Also, they get vascularity crashes. Vascularity crashes. Right? Amyloidosis of the kidneys also associated, as you can see in this picture. Right? Amyloid. They can get also a membranous glomerulonephritis and a tubulointerstitial nephritis. Right? Now, quadriplegia is a rare but dangerous side effect of rheumatoid arthritis, and that is because of what? That is because of atlantoaxial subluxation. Atlantoaxial subluxation. So, panino atlas axis dislocate penna puluwan, and that can cause cervical cord compression. And if you have done an anesthesia appointment, they might have told you that they are very careful when intubating patients with rheumatoid arthritis, because if you manipulate the neck too much, they can get dislocation of the atlantoaxial joint and cause quadriparesis. Tanushan, do you have a question? Okay.
No, so sorry, sir.
Fine. So this is definitely an important area for MCQs. Is that complications, extra-articular manifestations, and complications are something that you need to remember. Right? Even in the long case, you can get a patient with rheumatoid arthritis. It's not very common long case, but possible long case.
සර් මේ quadriplegia එක extra articular විදියට ගත්ත හැකිද ඒක articular එක complication එකක් නිසා?
ඒක දෙවිදිහටම හිතන්න පුළුවන්. ඒක නියුරොලොජිකල් කොම්ප්ලිකේෂන් එකක් තියෙන නිසා නියුරොලොජි කියලා කියන්නත් පුළුවන්. නැත්නම් ජොයින්ට් කියලා ගන්නත් පුළුවන්. ඒක ප්‍රශ්නයක් නැහැ. මෙතන අහලා තියෙන්නේ එක්ස්ට්‍රාට ඒක ප්‍රශ්නයක් නැහැ. ඒක එහෙම හිතලා ඕක ෆෝල්ස් කියලා ගහන්න එපා. හරි?
සර් පයෝඩර්ම ගැන්ග්‍රීනොසම හරිද?
හරි හරි. පයෝඩර්ම ගැන්ග්‍රීනොසම එනවා. Yes. That is associated. Okay, right. Now, this next MCQ focuses on investigation findings in rheumatoid arthritis. Now, before we go to this MCQ, I think you need to sort of have a look at this, which is the ACR-EULAR diagnostic criteria for rheumatoid arthritis. So this diagnostic criteria has 4 components. The first component is joint involvement. So you get a score based on the joint pattern, right? Serology is another important domain, and here we use rheumatoid factor and anti-CCP, rheumatoid factor and anti-CCP. Okay. Then you have acute phase reactants like CRP, ESR. And remember, to diagnose rheumatoid arthritis, you should have a duration of symptoms more than 6 weeks, right? More than 6 weeks. ඊට අඩුයි නම් rheumatoid වගේ නම් you call it early arthritis. එහෙම කියලා එකේ අලුත් terminologies තියෙනවා ඒකට. But to make a diagnosis of rheumatoid arthritis, the symptoms should be there at least for 6 weeks duration, right? So this is the diagnostic criteria for rheumatoid arthritis. Now, if you take the serology or the immune criteria, you have anti-CCP and rheumatoid factor. Okay. Now, anti-CCP is supposed to be more sensitive and specific than rheumatoid factor for rheumatoid arthritis. And it is associated with early disease, right? So anti-CCP can be used to diagnose quite early disease, right? And it is more sensitive and specific than rheumatoid factor. Now, these are a few important MCQs about rheumatoid factor and anti-CCP. So as I told you, anti-CCP has it's actually, a similar sensitivity but a higher specificity. So similar sensitivity, higher specificity. And as I told you, it has a very important role in diagnosing early rheumatoid arthritis. That is very important, right? Early disease. Okay. Tapare. Right. Now, again, the important things, MCQ points, slide anti-CCP has a higher rate of positivity in smokers, and it has a very good prognostic value, right? So if you have a higher titer of anti-CCP, that means that they have more aggressive and erosive disease, right? So that is very important to remember. So their disease is more aggressive and erosive if they have positive anti-CCP. Right. Now, but the problem in Sri Lanka is anti-CCP is not available in the government sector. So what we commonly use is rheumatoid factor. So rheumatoid factor is found in about 80% of patients. And it is an IgM antibody. Right? Now remember, the problem with rheumatoid factor is it is not specific for rheumatoid arthritis. Now the advantage of anti-CCP is a much higher specificity, right? Much higher specificity. But rheumatoid factor is not that specific. And MCQ rheumatoid factor can also be found sometimes in healthy people. Sometimes in family members of patients who have rheumatoid arthritis and other rheumatological conditions sometimes. Now, like you saw in anti-CCP, high rheumatoid factor indicates poor prognosis, right? So higher titers of rheumatoid factor, more erosive, more progressive disease, and they have a higher incidence of extra-articular disease. So rheumatoid factor again, like anti-CCP, has a good prognostic relevance or a prognostic significance. People who have higher titers have worse disease, more erosive, more severe disease, and also extra-articular disease. So let's go back to this MCQ. Anti-CCP has higher specificity than rheumatoid factor. So sensitivities are very similar, but specificity is much higher. Rheumatoid factor positivity is an indicator of poor prognosis. Yes, it indicates more severe disease, it indicates more progressive disease, more joint erosions, and also extra-articular disease. In rheumatoid arthritis, it is a lymphocytic aspirate most of the time, but you can get neutrophils as well. Right? It depends on the stage of the disease that you look at. In a flare, it is mostly neutrophil. A MCQ statement එක එච්චරම හොඳ නෑ. ඒක කරන වෙලාව අනුව වෙනස් වෙනවා. In chronic rheumatoid arthritis, it is mostly lymphocytes. But if you take a flare of rheumatoid arthritis and do aspirate, you might find prominent neutrophils. So that's not a very good MCQ. Pleural effusions have low glucose, which is true. Right. Now, if you take X-ray changes in rheumatoid arthritis, right, they are late features. Remember, they are late features, right? In early rheumatoid arthritis, X-rays may be completely normal. X-rays may be completely normal. But with time, you can see erosions and other features, right? But erosions are not the earliest manifestation that you see. Right? Erosions are not the earliest manifestations. But actually, one of the earliest things you see is slightly widened joint space. Right? Slightly widening of joint spaces. That is one of the first things you see. Erosions are definitely a late feature. Right? They are definitely a late feature of the disease. And later feature is the joint deformities. Right? Even more later, you get the joint deformities. Right? Okay. So they are definitely not earliest manifestations of X-ray. X-ray initially what they get is a bit of widening of the joint space. That is one of the, it's unusual, but that is one of the first things that you can actually see. And then erosions come much later than that. Right. Any questions about those things? So, but we have talked about the joint pattern and about investigations in rheumatoid arthritis, about anti-CCP and rheumatoid factor, and about X-ray changes. So remember, X-ray changes are generally late, right? In early disease, X-rays might be completely normal. And even then, things like erosions and deformities are late features. Any questions? Hari, okay. Now, this MCQ is focusing on management of rheumatoid arthritis. Right. Now, whatever thing you do, you should start in rheumatoid arthritis. The mainstay of management is you should start a disease-modifying drug at the diagnosis. No delay, no katandara. For anyone with a diagnosis of rheumatoid arthritis, the recommendation is start DMARDs as soon as possible. Right? Start DMARDs as soon as possible. As soon as possible. Okay. So the first statement saying reserved for patients with radiological evidence of joint injury boru katawak baila katawak. Hari eka වැරදි. So you give disease modifying drugs to all patients at the diagnosis. Right. Now the problem with disease modifying drugs is that they take time to start working. They usually take more than 3 weeks to start working and about 4 to 6 weeks to achieve remission. Right. So that is the slight problem with disease modifying drugs, right? Because the disease modifying drugs take time to kick in. They take time to start working, right? It takes about at least more than 3 weeks to start working and about 4 to 6 weeks for the disease to go into remission. Remission can control when the disease. So the second statement is false. You never get disease remission within 3 weeks. That is too fast. You will never get such a quick disease remission. Now, if you take the DMARDs, there are three types of DMARDs, right? Number one, conventional synthetic DMARDs. Conventional synthetic DMARDs. Conventional synthetic DMARDs. They can use methotrexate වගේ දේවල්. Methotrexate, leflunomide are examples for that. Then you have biologic DMARDs. Biologic DMARDs. Biologic DMARDs can use infliximab වගේ දේවල්. Right? Biologic DMARDs. Biologic DMARDs. And then over the last few years, there is a new type of DMARD, which is called a targeted synthetic DMARD. TS DMARD. And that is usually a JAK inhibitor. The name of the drug is tofacitinib. Tofacitinib. That is a targeted synthetic DMARD. It is available in Sri Lanka, but not in the government sector. Tofacitinib. Tofacitinib. Now, about how you use these drugs, the only thing you should know, Lamai, is that methotrexate is the first line drug. There is no question about that. Right? Diabetes metformin kiwwa, there is no question that for rheumatoid arthritis, the first line drug is methotrexate. There is no doubt about that. Right? No doubt about that. Right? If methotrexate does not work, right? Methotrexate does not work, right? You can consider adding on a second drug like leflunomide or sulfasalazine. So methotrexate is the first line drug. If methotrexate does not work, then you can consider adding on a second line synthetic, conventional synthetic DMARD. Hari. Habai, if methotrexate fails, right, and there are poor prognostic factors, right? Already we have talked about the most important poor prognostic factor is the high rheumatoid factor anti-CCP level. That is the most important poor prognostic factor. So if the methotrexate fails and they have poor prognostic factors, so high rheumatoid factor, high CCP, extra-articular disease, another poor prognostic factor, if you're seeing early joint erosions, right, in the disease, if those are, that's the case, you might directly go for a biologic DMARD or a JAK inhibitor. Right? So you can write at the start, rheumatoid arthritis, at diagnosis, you start methotrexate. That is the first line drug. If there's a contraindication, you can consider leflunomide sulfasalazine. And then you look for remission, and remission takes long, right? Remission takes long, I told you, beyond 6 weeks. Definitely, beyond 6 weeks, remission right? Right? If methotrexate does not work, if they don't have any poor prognostic factors, you can add on another conventional DMARD like leflunomide. But if they have poor prognostic features like early joint erosions, high rheumatoid factor, anti-CCP, the recommendation is to use a biologic DMARD or something like tofacitinib, right? Okay. Right. And you already know a lot of adverse effects of methotrexate. Methotrexate can cause hepatotoxicity, and methotrexate can cause neutropenia, agranulocytosis, neutropenia, right? Another important side effect of methotrexate, it can cause a subacute pneumonitis. Subacute pneumonitis. Long case right? HCQ is also sometimes used for rheumatoid arthritis, and it can cause a maculopathy, bullseye maculopathy. මෙතන වගුවක් දීලා තිනවා ඔයගොල්ලන්ට important side effects ටික ඔය බෙහෙත් වල ඒ ටික පොඩ්ඩක් බලා ගන්න. හරි. Right. ඒ ටික පොඩ්ඩක් බලා ගන්න. Right. Now, leflunomide is also quite a a popular drug for rheumatoid arthritis. And remember, leflunomide can cause a lot of side effects, and it has a teratogenic potential, right? And if you are on leflunomide, you need a washout period before pregnancy, right? So it's about, you need a 2-year washout in females. You can accelerate the washout with something else. You don't have to worry about that. But usually a long period of washout is recommended after leflunomide before they become pregnant. Right? For males, it's about 3 months. Okay, right. Any questions about rheumatoid arthritis? So I've summarized the management. ගොඩාක් detail අහන්නේ නැහැ ළමයි. These are very complicated areas in medicine, very specialist areas, so they'll just ask the basics. Okay, so just the management principles. Methotrexate being the first line drug, you need to know the side effects of methotrexate, and also poor prognostic features. Biologic DMARDs or posh drugs, right? And then if not, you can add on other usual DMARDs like leflunomide, sulfasalazine, right? Leflunomide or sulfasalazine.
Excuse me, sir. So still, do we still we use steroid for initial?
Oh, yes. So I forgot to mention that. Sorry. So now I told you that DMARDs take time to work, right? So you use steroids for bridging effect, right? And that is usually a short course of steroids, say about 3 weeks until the disease modifying drugs kick in, right? That is the usual way that you do it. Right. Another thing that I would like to mention here is that for rheumatoid arthritis, there are disease activity scores, right? So a common example of that is something called the DAS28. එක MCQ වලට අහුවොත් එක මතක තියාගන්න. DAS28. That is a disease activity score. Disease activity score. Okay. Right. Okay. Now, in the long case, I introduced this word spondyloarthritis to you, and the classical example within that group is ankylosing spondylitis. Long case certain common features about spondyloarthritis. So common features about spondyloarthritis long case make a Number 1, commoner in males. Commoner in males. Commoner in males. Number 2, so number 1, commoner in males. Number 2, there is a strong familial association of spondyloarthritis. Runs in families. Tuna, spondyloarthritis are associated with HLA-B27 positivity. HLA-B27 positivity. Hatara, spondyloarthritis classically affect the axial skeleton, spine, and also the sacroiliac joints. So spine, sacroiliac joints are commonly involved. They can also affect the lower limb large joints, right? Lower limb large joints can also be affected, and it is affected in an oligoarthritis pattern. Oligoarthritis of the lower limb large joints is associated. So males, familial, HLA-B27, axial skeleton is commonly involved. Lower limb large joints can be affected also. I also, in the long case, told you that these spondyloarthritis tend to affect other parts of the musculoskeletal system, like the tendons, entices, which are tendon insertion points, and also fascia. So you can get inflammation of the tendons, inflammation of the entices, and inflammation of fascia, like plantar fasciitis. That is also associated. And then finally, they can also have various extra-articular manifestations, right, which are listed in point 4 in this slide, like uveitis, aortic regurgitation, and upper lobe, upper lobe pulmonary fibrosis. Upper lobe pulmonary fibrosis. So that is the typical common pattern of spondyloarthritis. Of those, ankylosing spondylitis is the sort of prototypic disorder or classical disorder that we talk about. But there are other causes of spondyloarthritis, like some types of psoriatic arthritis, for example. Okay. So ankylosing spondylitis is more common in females, more common in males. Plantar fasciitis is a presenting feature, right? Aortic regurgitation is known to basal lung fibrosis upper lobe lung fibrosis. Extraarticular manifestations. So pulmonary fibrosis is mainly the upper lobe that you get, right? Upper lobe that you get. So ankylosing spondylitis and most of the spondyloarthritis are actually common in the thoracolumbar spine, right? Not in the cervical spine. You can get it in the cervical spine, but it is commonly in the thoracolumbar spine that it starts off. Then it can involve all parts of the spine, right? Right. So this is what I told you. Changes commonly seen in the lower thoracic and upper lumbar spine. And you know that you get this typical bamboo spine appearance, where there is calcification and thickening of all the sort of joints and ligaments around the spine. Bamboo spine, right? So you get all these thickening, calcification of the spinal joints, and also the ligaments of the spine, calcified and thickened. And that ultimately gives rise to a bamboo spine. They also get these small sort of processes called syndesmophytes. Spelling syndesmophytes. Small protuberances, processions. Okay. Right. But actually, the X-ray changes occur late, and MRI scans are supposed to be the gold standard to diagnose this spondyloarthritis. And you can see changes very early on the MRI scans, much earlier than you see them on X-rays. Much earlier. So now, currently, MRI is fastly recommended as the investigation of choice for these spondyloarthritis. Okay. And management is with physiotherapy, NSAIDs, and mainly TNF-alpha blocking biologics like infliximab. And you monitor the response to these with tests like the Schober's test, which examines the flexion of the lumbar spine, right? Schober's test. That's a useful way of treatment monitoring. Okay, and as well as diagnosis. So, true or false regarding ankylosing spondylitis? Schober's test is useful for diagnosis and disease monitoring. Now, with time, because ankylosing spondylitis affects the whole spine, it can also affect the joints between the ribs and the vertebrae, and that can affect the chest expansion, right? When it affects the cervical spine, it can also affect the flexion and extension of the neck. So, mulu spine nekama yana. We talked about radiology. The calling slide radiology. Radiology, we told that there is syndesmophyte formation, there is thickening and calcification of all the vertebral joints, as well as the ligaments in the vertebral column. Right? So, syndesmophyte formation is something that you see. X-rays are late, X-ray changes are late, and MRI changes are far more sensitive to pick up early disease. Right? Sulfasalazine is not very useful, as I told you. NSAIDs and infliximab are the main drugs that we use. එතන පොඩ්ඩක් තරුවක් දාලා ලියා ගන්න. Sulfasalazine may be effective for people who have I told you that can also affect the lower limb large joints. So if they have peripheral joint involvement, sulfasalazine might be of use කියලා ලියා ගන්න. But for the spine, sulfasalazine is useless. Right? Sulfasalazine is useless for the spine. Things like infliximab are much more effective. But if they have a peripheral joint disease in association, sulfasalazine might be used. Right. Any questions about ankylosing spondylitis?
So, are nail changes, are they specific to psoriatic arthritis or can they be there in other types as well?
They are mostly suggestive of psoriatic arthritis. Right? Among psoriatic arthritis, can වචනයක් කියන්නම්. So psoriatic arthritis has a lot of patterns, right? So psoriatic arthritis can present like rheumatoid arthritis. ඒ වගේම present වෙන්න පුළුවන්. Right? So ඒකත් පොඩ්ඩක් ලියා ගන්න මට ඇත්තටම ඒකට කියන්නේ MCQ එකක් දාන්න අමතක වෙලා ඉතින්. කමන්නේ ඉතින් මම අහන්නේ ඔය ටික කියන්න. So psoriatic arthritis can have a pattern very similar to rheumatoid arthritis. The main difference there is obviously you have the skin and nail changes, and also you get DIP involvement in psoriatic arthritis. Right? DIP, distal interphalangeal joint involvement. Right? Distal interphalangeal joint involvement in psoriatic arthritis. And you also see these are very severe joint erosions in psoriatic arthritis. Penicillin cup appearance කියලා වගේ දේවල් හොඳටම erosions එනවා. And this is in the distal interphalangeal joint. So you have very prominent distal interphalangeal joint involvement and erosions in the distal interphalangeal joint. Right. Now, apart from that polyarthritis pattern, psoriatic arthritis can also present with a spondyloarthritis pattern, where there is mainly axial skeleton involvement and sacroiliac joint involvement. එහෙමත් present වෙන්න පුළුවන්. හරි. ඒවා හැම එකම skin changes, nail changes you will see. And they are considered to be very specific for psoriatic arthritis. Mahesh අහලා තියෙනවා, does HLA B27 have any therapeutic value? No, Mahesh, it doesn't. It is mostly for diagnostic purposes. Okay. Right. Now the next MCQ is on another type of spondyloarthritis. වගේ present වෙන්න පුළුවන් එකක්, reactive arthritis. So reactive arthritis again is HLA B27 positive. And there are lots of infectious agents which are associated with reactive arthritis. Right? So penicillin cup is usually in psoriatic arthritis, not in rheumatoid arthritis. Reactive arthritis is associated with certain infectious agents. And the list I have given, MCQ at අහනවා. And they can cause an axial skeletal involvement, but commonly a large joint monoarthritis. Okay, මේ කකුලේ එන particular rash එකක් තියෙනවා, keratoderma blennergicum කියලා. ඒක තමයි පින්තූරේ පෙන්නලා තියෙන්නේ. තව penis එකේ එනවා cercinate balanitis කියලා එකකුත්. Cercinate balanitis. Cercinate balanitis. And because it can cause a spondyloarthritis pattern, they have plantar fasciitis also. ඒ කතන්දරේ හැමම තියෙනවා. Right? And prognosis is good in HLA B27 positive people. Poor නෙවෙයි, good. හරි. මේක වැඩි අහන ඒරියා එකක් නෙවෙයි. ඒකයි මම ඒක ටට්ටක් ගාලා කරේ ලොකුවට අහන්න හැවුවා. But just remember the infectious agents that you get in association with reactive arthritis. And also remember it can present with a spondyloarthritis pattern, monoarthritis pattern. එකක් එන්න පුළුවන්. Right? And they also have these sort of skin manifestations which are special, like keratoderma blennergicum and cercinate balanitis, which is a sort of penis inflammation, balanitis. Okay? Right. Any questions?
ගොනකොකල් වලට යනවා.
මොනවද?
ගොනකොකල් වලට reactive arthritis.
ගොනකොකල් වලට ගොඩක් වෙලාවට ගොනකොකල් ආත්‍රයිටිස් එකක් එනවා. right? reactive එකකුත් එන්න පුළුවන්, but mainly එකට එන්නේ ගොනකොකල් ආත්‍රයිටිස් එකක්. infection එක නිසා එන එක. Shigella, yes, I think, yes, can also cause reactive arthritis, but mostly salmonella. Right? Reactive arthritis is more common in males. So reactive arthritis, spondyloarthritis group eකට ඇතුල් වෙන හින්දා ගොඩක් males ලගේ තමයි. I think it's males more, males equal females or something like that. Okay, right. Now, this MCQ is on Still's disease, which is not very important. Still's disease is essentially a inflammatory disorder, and the typical feature is they present with fever, right? And this transient macular rash, maculopapular rash, transient. It comes in the height of the fever and then disappears. Right? So it's a transient maculopapular rash that comes on with the height of the fever and then gradually goes away. Right? That is a typical appearance. It's a salmon pink transient maculopapular rash. Right? Salmon pink transient maculopapular rash. They also have significant joint pain. Right? Now, I've given you a table with the common sort of manifestations. Commonly they get a neutrophil leukocytosis in the blood counts and also thrombocytosis. There's a lot of inflammation. So they get a neutrophil leukocytosis and thrombocytosis. So the first statement is wrong. Right? So fever, rash, neutrophil leukocytosis, thrombocytosis, and usually inflammatory markers are very high. Serum ferritin is very high, right? It is extremely high, right? It's extremely high. The rheumatoid factor A are by definition negative, right? And they can have, as I told you, they can have joint involvement, very severe joint pain. Cardiac involvement can occur, and they have pericarditis and pericardial effusions. They can also get pleuritis and pleural effusions. So they have a serositis as well, right? So pericarditis and pericardial effusions, and pleuritis and pleural effusions, which are a manifestation of serositis. Right? Serositis. So that's a little bit about Still's disease. මං හිතන්නේ ඔක ඉතින් MCQ එකට අහන්නම් ලොකු දෙයක් නැහැ. Best response එකකට නිකන් diagnose කරන්න වගේ කියලා දෙන්න පුළුවන්. හරි. මේ වගේ දෙන්න පුළුවන්, right? So the typical is very high fever, this typical salmon pink maculopapular rash, and this neutrophil leukocytosis with thrombocytosis. That is a typical story that you see. Right? And the investigations they can get pleuritis, pericarditis. Still's disease and systemic onset JIA are the same. Yes. Systemic onset JIA ගොඩක් ළමයින්ට පාවිච්චි කරන්නේ මේක adults ලගේ. It's essentially the systemic onset JIA in adults වගේ. Right? Sorry. Okay. Any questions up to now? ප්‍රශ්න තියෙනවද? Questions? Hari. Now let's move on next to crystal arthropathies. අපි බලමු crystal arthropathies. Crystal arthropathies. Now of the crystal arthropathies, gout is the most important. And obviously you know that in gout there is deposition of MSU crystals. MSU can monosodium urate crystals in joints. Now, the causes of gout are a frequent MCQ, right? So, what of the following cause gout? The principle behind it is anything that causes increased production of uric acid, right? Increased production of uric acid, or a condition that causes reduced uric acid clearance can cause gout. So the typical example of a condition that causes reduced uric acid clearance is renal failure. In nephrology, we talked about this. A classical thing that causes increased production of uric acid is high cell turnover states like myeloid and lymphoid malignancies. Increased cell death and increased cell turnover. Are it? Okay, increased cell death and increased cell turnover. Right? Plus increased production. So මේ MCQ එක ගහ ගන්න පුළුවන්. වෙන්න ඕනේ. මෙතන ඔක්කොම ඕනේ ටික එතන තියෙනවා. Right. Now, typically gout presents with inflammation of the first metatarsophalangeal joint, as you can see in the picture. There is inflammation of the first metatarsophalangeal joint. But remember that gout can also have a more chronic form, which is characterized by polyarticular involvement and tophi, right? That's seen in the picture on the right side of your screens, right? So common presentation, acute common presentation is the first metatarsophalangeal joint involvement, but you can get a polyarthritis with tophi appearance as well. There are various forms of the disease. Right. Acute attacks of gout have a predilection for the first metatarsophalangeal joint. That is absolutely true. Right. Now, gout presents with acute joint pain. Acute joint pain. And sometimes mimics septic arthritis. Very important. Mimic septic arthritis in many ways. So acute joint pain, joint inflammation. And if you aspirate the fluid, you will find neutrophils, a whole lot of neutrophils. So it is a very close differential with septic arthritis. So they have acute joint pain, inflammation of the joint. If you aspirate the joint, you might get a lot of neutrophils. So that is, it parallels it very closely. So how do you differentiate the two? Obviously, in septic arthritis, you might be able to stain or culture microorganisms. Whereas in gout, you can look for crystals, right? You can look for crystals. And gout will negatively biofringent crystals. And in this picture, you can see a lot of neutrophils. Neutrophils in the, this is joint fluid. Neutrophils and also these negatively biofringent crystals. Right? Positively, negatively biofringent crystals. So remember, the important take-home message from there is that gout can mimic septic arthritis, can cause a neutrophilic infiltrate into the joint fluid. But you will see this typical classical crystals, negatively biofringent crystals in gout. Right. Another very important MCQ point is the serum uric acid levels may be normal in a flare-up of gout. That is important, right? They are usually normal in a flare-up of gout. MCQ වලට අහනවා. Right. So again, this typical monosodium urate crystals, which are negatively biofringent. The positively biofringent are this calcium pyrophosphate crystals. They are positively biofringent. And the shape of the crystals also very different. So gout needle-shaped crystals. Here you get more rhomboid or rod-like crystals in calcium pyrophosphate dihydrate crystals, which are CPPD or pseudo gout. Right? Okay. Right. Now I showed you a picture. So in gout, ESR CRP is high. Right? They are high. So it's exactly like a full-blown inflammatory infective present. They have inflammation, high ESR, high CRP, neutrophils in the joint fluid. Sometimes the only way to differentiate is to use the look for crystals. Look for crystals. Right. Now in the very first picture, I showed you a picture of acute gout, which is this typical first metatarsophalangeal involvement. But I also told you in some people, they can develop a more chronic form of gout, which has polyarthritis and gouty tophi. Now, in those sort of people, you get this sort of appearance on the X-rays where you see a lot of punched out periarticular erosions. Thatටම තියෙනවා මේ බලන්න මේ පංචර් එකකින් ගැහුවා වගේ හිල් හැදුවා වගේ erosions එනවා. Which is different from the pattern you see in rheumatoid arthritis, which is a more marginal erosion එකක් කියන්නේ rheumatoid arthritis. Here it's නිකන් පංචර් එකකින් ගැහුවා වගේ punched out appearance එකක් එන්නේ. Right? And you can see these soft tissue swellings are gouty tophi. Your soft tissue swellings are gouty tophi. Right. So management gattut acute episode in NSAIDs. Some people use short course of steroids and colchicine. Those are the commonly used drugs. Some people will need sort of chronic hypouricemic therapy. Right? And this is specially indicated in people who have renal impairment, right? Recurrent acute episodes, right? And tophi. So people who have renal impairment, tophi, and recurrent acute episodes will need prophylactic therapy. And the drug of choice is allopurinol. Allopurinol. Right. So something, an MCQ about chronic tophaceous gout, which is the chronic form. So gouty tophi occur in the, as you can see in the first picture I showed you, in the fingers, but they can occur anywhere. And typically you see this appearance in the earlobes or the pinnae, right? So gouty tophi can occur in the pinnae. Chronic tophaceous gout can be seen in renal disease because they have long-standing elevation of uric acid because of poor excretion. I just showed you a picture of punched out erosions in the X-rays, erosions or cysts in the X-rays. Right? And obviously I told you that chronic tophaceous gout is an indication for hypouricemic therapy or prophylactic therapy as well. Right? Prophylactic therapy. මේ පස්වෙනි MCQ එක මෙතෙන්ට අදාළ දෙයක් නෙමෙයි ඒක වැරදිලා මෙතෙන්ට අවිලා තියෙන්නේ. So you don't usually give hypouricemic therapy after a single attack of gout unless you have these things like tophi or renal impairment or recurrent episodes of. Okay. Any questions? No. Yeah, so at the acute attack ekadi uric acid adu wennat puluwa. So normal or low. So there is no absolute specific time, but remember when you are treating gout, you treat the acute episode first and then start the allopurinol once the disease is stable. That is the usual way that you give it, right? So white gout, everything is high sharp. Inflammation එකක් වගේ. Okay, right. So let's go to SLE then. Right. Right, ඉතින් බලන්න වෙන ප්‍රශ්න මොකුත් තියෙනවද බලන්න. Right. SLE we talked about during a long case discussion. Right. So most of the points I've already covered there. Now SLE, as you know, is far more common in females. The pathogenesis of SLE involves some genetic predisposition as well as some environmental factors. So the pathogenesis of SLE right? Pathogenesis of SLE partly has a genetic component, but also has a more of an environmental contribution. And some of the important okay, right. So there are certain genetic factors and environmental factors, and certain drugs can also precipitate SLE episodes, right? Procainamide, hydralazine, and all of you have seen the very typical butterfly malar rash of SLE. Right. So let's do this MCQ then. True or false regarding SLE? More common in females? Yes, that's true. Disorders of the complement pathway are implicated in the pathogenesis. So yes, there are certain genetic disorders in relation to complement deficiencies that can cause SLE. Hydralazine as well as procainamide is known to cause drug-induced lupus. Right, drug-induced lupus. Right, OCP not very much. We could. It can, theoretically it can, because pregnancy can also, pregnancy hormones can precipitate, but that I have not commonly seen that happen. Right. Now, I talked about this MCQ point where we talked about how to diagnose an active flare of SLE. Long case right? So how to diagnose a flare of SLE. So in a flare of SLE, they get leukopenia with lymphopenia. Right? Leukopenia with lymphopenia. In an active flare of SLE, they will consume complement. So their C3, C4 are low. Right? So because they are consuming, using up complement, their C3, C4 are low. Right. Number 3, ESR is high, but CRP is normal. ESR is high, but CRP is normal. These are the 3 important sort of laboratory measures that we use to diagnose and a flare of SLE. Right? So high ESR, normal CRP, lymphopenia, leukopenia, and low complement. Right? ESR, CRP, dekama badi nang SLE patient කෙනෙක්. Right? If an SLE, write this down very clearly. If an SLE patient has both high ESR and CRP, you have to either think of an infection, right? So this can happen when they have an infection, or when there is serosal involvement. Right? Serosal involvement, you can have both ESR and CRP going up. Serosal involvement. Right. Right. This is not so important. There is a new criteria for SLE. This is not really a diagnostic criteria. Actually, it is more of a criteria for selecting patients for research, clinical trials. Right? Right. Now, this MCQ is mostly about management of SLE. Anti-Smith antibodies are specific for SLE. Right? So, there are several types of antibodies that we measure, right, in SLE. Right? මෙතන මේ බලන්න මේ table එකේ ඒක පොඩ්ඩක් බැලුවට කමක් නැහැ. Right? So there are two SLE specific antibodies ළඟ. දෙකක් තියෙනවා. Remember ANA is not specific for SLE එක ඔබ දැනගන්න ඕනේ. But there are two SLE specific antibodies. One is anti-dsDNA එක ඔබ දන්නවා. Anti-Smith antibody is also considered to be specific for SLE. Anti-Smith. මෙතන ලියා ගන්න anti-Smith වලට අමතරව anti-dsDNA උත් SLE specific කියලා. So exacerbations are known to occur in pregnancy, and I also went through with you a list of other things that can precipitate SLE. Right? තව කීපයක් අපි කතා කරා. Right? Especially drugs. Right? Now, all SLE, in the management of SLE, all patients are recommended to be started on hydroxychloroquine. And there are lots of effects which are a bit too much for you, lots of benefits of doing that sort of thing. Right. Right. And in the long case, we discussed things about renal lupus management. So I told you that as a general rule, as a general rule, if they have life-threatening disease like class 4 lupus nephritis, aggressive renal disease, you use high dose steroids and things like cyclophosphamide or MMF. හොඳටම කන පැලෙන්න immunosuppress කරනවා. කන පැලෙන්න immunosuppress කරනවා. Right? කන පැලෙන්න immunosuppress කරන්න ඕනේ. So high dose steroids, cyclophosphamide, MMF, if they have life-threatening organ problems. Sorry. But patients with mild disease don't need steroids or strong immunosuppression. They just need HCQ. So SLE management is very complicated, but if you just remember, if they have very severe organ-threatening, life-threatening disease, high-dose systemic steroids, strong immunosuppression, කන පැලෙන්න ගහනවා ඒවා. Right? Like cyclophosphamide, MMF. Right? But the other group which have milder symptoms, HCQ විතරයි. ඇති. වෙන මුකුත් කරන්න අවශ්‍ය නැහැ. So systemic steroids I need all patients කියන එක බයිලා කතන්දරයක්. And MMF or cyclophosphamide දෙකම can achieve remission in renal lupus. දෙකම හරි. Cyclophosphamide, MMF දෙකම හරි. Yes, Sajid, HCQ is given lifelong in patients with SLE. All patients with SLE, regardless of mild, severe, should be given HCQ. And මතකයි side effect එක HCQ වල bullseye maculopathy. මේක වැඩක් නෑ එච්චරම. Giant cell arteritis ගැන ඔයගොල්ලන්ට neurology වල පොඩ්ඩක් කතා කරනවා, but the other vasculitis are not very important. හරි? Giant cell arteritis උත් MCQ වලට වගේ අහන එකක් නෑ. I will just tell you some important points about it, right? But not very important. So giant cell arteritis typically presents with a temporal headache, right? They are, Professor Chang have told you, they are usually more than 60 and their ESR is more than 60, right? So more than 60, ESR more than 60, they present with a temporal headache, unilateral temporal headache. And it's very significant tenderness over the temporal arteries. Right? The term tenderness over the temporal arteries. Right? Tenderness over the temporal arteries. Okay, right. How you diagnose it is, one, you can measure the flow. So what happens in temporal arteries, there is inflammation and occlusion of the temporal arteries. So you can measure the flow on the temporal arteries with a Doppler of the temporal arteries. Right? And you can also do a biopsy. temporal artery biopsy. Harine, so age more than 60, ESR more than 60, temporal headache present when. And you can do a temporal sort of Doppler ultrasound and a temporal artery biopsy for diagnosis. Now, sometimes temporal arteritis can cause blindness because of retinal vascular involvement. And it can also be associated with polymyalgia rheumatica, which causes pain and stiffness of the proximal muscles. Pain and stiffness of the proximal muscles. Right? This headache in temporal arteritis has a dramatic response to steroids. Dramatic response to steroids. Dramatic response. Tunna gavam bongala pariyana. එක දවස දුන්නා ඊගාව දවස් වෙනකොට headache එක කොහෙ ගියාද නැහැ. And sometimes you use this for diagnosis as well. Right? Sometimes you use this as diagnosis as well. Again, diagnosis කියන්නේ steroid දුන්නා ඊගාව දවස් හොඳ වෙලා නම් ආදැන් අපිට sure that this is giant cell artery. It's such a dramatic response. Such a dramatic response. හරි. ඔය කරුණ ටික ලියාගත්ත නේද? So ESR more than 60, age more than 60, temporal headache, tenderness of the temporal arteries, and they are pulseless. Doppler ultrasound scan with biopsies diagnosis, and then steroids sort of dome gala respond කරනවා කියන එක. ඒ ටික මතක තියාගන්න. හරි. Okay. Right. Last thing is osteoporosis. Osteoporosis එකේ definition එක මෙතන තියෙනවා. All of you know that it is defined as bone density below 2.5 of the peak bone mass. Right. How do you diagnose osteoporosis? Use a DEXA scan, right? And all patients should undergo a fracture risk assessment. Fracture risk assessment. There is a score called the FRAX score. FRAX, F-R-A-X, FRAX score. That has been optimized for use in Sri Lanka, and there is a whenever country FRAX score, right? And that gives you an idea of the fracture risk. Right, fracture risk, which is very useful in deciding treatment. It's a very complicated area, so I don't need you to worry too much about this. Right? Almost anything under the sun can cause osteoporosis. Meta loku laistuවක් තියෙනවා ඕන මගුලකින් osteoporosis එන්න පුළුවන්. But the two common causes are post-menopausal osteoporosis and steroid-induced osteoporosis. Right? Steroid-induced osteoporosis. And post-menopausal osteoporosis. Right.
So we will make calcium phosphate level normal then? No.
Osteoporosis is there?
Oh.
Okay. Right. So almost anything under the sun can cause osteoporosis, but the common things are postmenopausal and steroid-induced. Osteoporosis is just a reduction of the bone density. There is no change in the calcium phosphate or vitamin D or ALP. It's just the bone density is reduced. Right? Bone density. Now, how would you treat osteoporosis? Osteoporosis treatment, there are several drugs which are used. Now, commonly used drug එක විතරක් කියලා දෙන්නම්. මොකද ගොඩාක් drugs තියෙනවා. ඒවා ගැන ඔයගොල්ලෝ දැනගන්න අවශ්‍ය නැහැ. Drug treatment is decided obviously on the the bone mineral density value plus the fracture risk. ඔය දෙක අනුව තමයි අපි සාමාන්‍යයෙන් drugs decide කරන්නේ. ඒවා ටිකක් අමාරුයි ඔයගොල්ලන්ට ඒවා guidelines it's complicated. Those are definitely postgraduate things. But you should know something about bisphosphonates, which are commonly used for osteoporosis management, like alendronic acid. The main action of bisphosphonate is to inhibit osteoclast function. Right? That is the most important mechanism of action. Right? And the common drug that we use, as I told you, is alendronate, which is used once a week with it. Now the problem with alendronate is that it causes a lot of gastroesophageal problems, irritation, gastric irritation, esophageal irritation, esophageal irritation, right? Gastroirritation, esophageal irritation. And a very rare side effect, but important side effect, is osteonecrosis of the jaw, right? And is common with IV preparations actually. Right. Now, steroid-induced osteoporosis is a particular problem. Any dose of steroids can cause osteoporosis. Any bloody dose. Any dose of steroids can cause osteoporosis. But the risk is higher and treatment is recommended. Treatment is prevention, right? Prevention. Right? So any dose of steroid can cause osteoporosis. But prevention is recommended when you're on prednisolone, usually more than 7.5 daily for 3 months or longer. That is the usual guideline. Sorry. But remember, any dose of steroids can cause osteoporosis. But prophylactic bisphosphonate therapy is recommended at this level of steroids, right? 7.5 milligram daily for 3 days. That is prednisolone for 3 months or longer. Okay, right. So osteoporosis is a very complicated area, mostly postgraduate. Okay, right. Okay. Right. So let's quickly go through the best response MCQs also. Rheumatology, nothing else. මෙතන මේ ලොකු කතන්දරයක් දීලා තියෙනවා. DMARD මොකද first line drug එක මම දැන් කිව්වා කට ගැටන එක methotrexate කියලා. Right? So methotrexate is the first line drug. If the patient is intolerant to methotrexate, මම කිව්වා මොනවද? leflunomide or sulfasalazine. And then you watch for the response. And the response can take a long time. Remission can take a long time. 3 months, sometimes 6 months. පටන් ගන්න remission 6 weeks විතර කියලා මම කිව්වා. Effect එක පටන් ගන්න after 3 weeks. Remission වෙන්න පටන් ගන්නවා about 6 weeks, but maximum sometimes can go on for longer, 3 months, 6 months වෙනකම් බලන්න ඕනේ සමහර වෙලාවට. But methotrexate is the first line drug, no doubt about that. Right. A 50-year-old woman has severe rheumatoid arthritis. PL කතන්දරයක් තියෙනවා නේද? මොකද්ද මෙතන වෙලා තියෙන්නේ? So we'll do hematology tomorrow and you'll be better at this now. But essentially, there is a pancytopenia with low retic percentage. Right? Bone marrow problem. And that is something that you see with methotrexate therapy. But when you have pancytopenia with low retic response, that is a bone marrow failure. And bone marrow right? And that is something that you see with methotrexate. Detail hematology. Right. So මෙතන rheumatoid arthritis කතාවක් තියෙනවා, dry cough තියෙනවා, saturation අඩියලු අරක මේක interstitial infiltrate එකක් තියෙනවා. මොකද වෙලා තියෙන්නේ? This is methotrexate induced pneumonitis එකක් තමයි මේ වෙලා තියෙන්නේ. මේක මෙතෙන්ට අදාළ එකක් නෙවෙයි. මේ ඇත්තටම TB මම TB ගැන හෙට උගන්වන්නම්. TB ස්පයින් නම්බරක් ගැන. right. මේ මොකද්ද මේකේ උත්තරේ? congestive heart failure furosemide පටන් අරන් එයා අහන්න දෙයක් නැහැ. මොකද්ද? monoarthritis එකක් එනවා, inflammatory monoarthritis එකක් එනවා, gout. Gout is the answer. Hi. පොඩ්ඩක් ඉන්න අදාළ ඒවා ටික විතරක් කරමු. Right. හතර පොඩ්ඩක් කරමු. 65-year-old female with rheumatoid arthritis. Rigid non-tender spine, bilateral grip weakness, reflexes increased in upper lower limbs, bodies. මොකද වෙලා තියෙන්නේ මෙතන? So most likely thing is rheumatoid arthritis. There is some sort of cord compression, cervical cord compression. So the answer is atlattoaxial subluxation. So 22-year-old female, SLE කතාවක් මෙතන තියෙන්නේ. So I told you in SLE all patients unless contraindicated should be put on hydroxychloroquine කියලා. Right. So ඒකේ උත්තරේ hydroxychloroquine. right. මේක පොඩ්ඩක් ඔයගොල්ලන්ට සැර වැඩි ඒක එපා. හරි මම මේක එක MCQ එකක් තිබ්බා ඒක ඕනේ නැහැ දැනට. හරි. Sarangani, you are still happy to do that MCQ paper, ne? The best